Hello, everyone. My name is Fatima Cordoso. I'm a medical oncologist and the director of the breast unit at the Champalimau Clinical Center in Lisbon, Portugal. I'm happy to be here today to discuss with you the treatment decision-making in the first-line setting of metastatic ER-positive HER2-negative breast cancer. I thank also the organizers for this kind invitation. These are my disclosures. And let's start by discussing how heterogeneous this group of tumors are. And we sometimes call it luminal-like tumors, so ER-positive, HER2-negative. And what are the implications for therapeutic decisions of this heterogeneity? So we can talk about heterogeneity from the patient point of view in terms of age, menopausal status, preferences that should always be taken into account, genetics and pharmacogenomics, as well as other determinants for toxicity. There is also disease heterogeneity, for example, presence or absence of visceral metastases, visceral crises, and also biological heterogeneity with certain mutations, alterations that may have therapeutic implications. Some of those are listed here. So let's dissect a little bit more about the biological heterogeneity. The most important characteristics of these tumors is what we call the luminal signature, and that has ESR1, GATA3, FOXA1, XBP1, and CMYC. And for those that have a more or a stronger therapeutic implication, we have the PI3K mutations for the moment. We also know that we have investigated a lot of predictive biomarkers for endocrine therapy as well as for endocrine-based therapy. For endocrine therapy itself, the only markers that we have are hormonal receptors. Perhaps in the near future, we may be able to use ESR1 mutations as a marker of resistance to aromatase inhibitors, but for the moment, it is not yet ready for clinical practice. We have no biomarker to help us decide between tamoxifen, aromatase inhibitor, or fulvestrant. Also for the targeted agents that we now combine with endocrine agents, we do not have validated predictive biomarkers for CDK4/6 inhibitors or for mTOR inhibitors. We do have a validated biomarker for the use of Alpalicip, and that is the mutation in PIK3CA. When we look at this clinical heterogeneity of these tumors, I simplify these by classifying these patients into three main groups. One, that are patients with a visceral crisis. So this is a very specific situation, and that fortunately is not very frequent, about 10 to 15%, including something that we may call impending visceral crisis, meaning that not yet with the characteristics of visceral crisis, but probably getting there quickly. Then we have another small group, about 15 to 20%, that we can call a group of cases with low burden of disease and less aggressive biology, for example, with a very long disease-free interval. And then all the others that are the vast majority of this subgroup. And this graphic, I will come back to that in the end of the talk to tell you about the therapeutic implications for the first-line setting decisions. So if we do not have a lot of biomarkers to help us decide, how do we decide? So we have to decide based on clinical questions, and this is the list of questions that we should ask when we are in front of a patient with this subtype of breast cancer. Let me make just a couple of points before going into the details of the treatment. So the treatment for premenopausal women is something that we've been fighting for a long time, that premenopausal women with metastatic disease should have access to all treatment options, as do postmenopausal women. the first recommendation for a premenopausal woman is the induction of menopause through ovarian function suppression or ablation. So from that moment on, they should be treated as postmenopausal. The same applies to men that should also be entitled to receive the same treatment options as that have been approved for postmenopausal women. How can we be sure about an adequate ovarian suppression? So we can do this by surgery. This is, of course, a more secure way. We can also do it by the use of LHRH agonists, and it is preferable, particularly for very young women, to use the 4-weekly schedule of an LHRH agonist. Radiotherapy can also be used, but it's not so effective and should not be the preferredly used. And we have to confirm that the ovarian function is actually suppressed, particularly before we start an aromatase inhibitor. This is very important. We cannot start both at the same time. We have to start the ovarian function suppression first, and then when we are sure that the ovaries are suppressed, add the aromatase inhibitor. So for this subtype of breast cancer, as I'm sure everyone now knows, endocrine-based therapy is the preferred option, even if you have visceral disease, even if you have liver or lung metastases. And this is for post, premenopausal, and men. What exactly is visceral crisis? We have updated the definition of visceral crisis, giving some examples to make it very clear that visceral crisis is not the presence of visceral metastasis, but you have to have a severe organ dysfunction that you see with signs, symptoms, laboratory studies, and the rapid progression of the disease, so that you have the compromise of the function of the organ. For example, liver visceral crisis implies that you have a rapidly increasing bilirubin, that it's at least 1.5 times the upper normal limit. And for this, you have to exclude that there is obstruction and also in the absence of Gilbert syndrome. For lung visceral crisis, you need to have a rapidly increasing dyspnea that is not due to pleural effusion. If you have a pleural effusion, first you do the drainage, and if the patient still has dyspnea after you treat the pleural effusion, then you can consider a visceral crisis. This only occurs in about 10 to 15% of patients. So when we decide on the first line therapy, we are going to decide endocrine-based therapy for the vast majority of patients. So first, let's choose the endocrine agents. So what can we use? We can use any of the three main agents that we have: tamoxifen, aromatase inhibitor, or fulvestrant. We have data for all of them. How do we choose? The most important factor is what has the patient received in the adjuvant setting and for how long. So if someone has received 5 years of an aromatase inhibitor or has a relapse while receiving an aromatase inhibitor, the preference should not be to give another aromatase inhibitor, but rather fulvestrant or tamoxifen. We have some trials comparing these agents. One of these trials is Falcon, that compare fulvestrant with anastrozole for exclusively de novo breast cancer patients. So these patients have never received endocrine therapy before. So what we see is that there is almost no difference between the two, a small PFS difference in favor of fulvestrant of about 3 months. Then there was a subgroup analysis that seemed to indicate that there is a bigger difference for patients without visceral disease, so mainly bone disease, as if fulvestrant would have a specific action in bone disease. We do not know the biological rationale, and for a long time I considered this just a chance finding. However, we now have another trial showing more or less the same thing. So you can see here in the Monarch 2 trial that for patients with bone-only disease, the difference is almost reversed in favor of fulvestrant. So, but at least you do not see a lot of the difference of the added benefit of abemaciclib, but you do see it in the visceral metastasis. Why? Nobody knows. And certainly this does not mean that fulvestrant does not work for visceral metastasis, but it's a research question that we need to bring back to the bench and analyze why fulvestrant has such a big impact on bone disease. Now, last year at ASCO, we also had a comparison of endocrine agents, this time letrozole versus fulvestrant, when we are giving a CDK4/6 inhibitors, and in this case, for endocrine sensitive disease. And what have we seen in this Parsifal study? No major difference between one or the other. So what we can neither, again, with a little bit difference between non-visceral and visceral disease, but what we can conclude is that we can use either an aromatase inhibitor or fulvestrant or also tamoxifen, and that the major factors for the decision of the endocrine backbone is previous exposure and patient preferences. So moving on now for the added targeted agent to the endocrine therapy agent. So now we have sufficient data to consider that CDK4/6 inhibitors are the standard of care for this subtype of metastatic breast cancer, not just because of PFS benefit, but mostly for the benefit seen in overall survival and for the positive impact in terms of quality of life. We can give a CDK4/6 combined with an AI or with fulvestrant. We can give it in de novo or recurrent advanced disease. We can give it in first or second line, and in cases of primary or secondary. And this is for postmenopausal, premenopausal women as well as men. The combination of a CDK4/6 with tamoxifen can be used with abemaciclib or palbociclib. There has been some data showing a higher risk of cardiac side effects if you combine it with ribociclib, and so it's not recommended to use tamoxifen and ribo, but you can use it with one of the other two CDK4/6. So this is the summary of all trials that look into these agents in the first-line setting. And you can see a very consistent 10 to 14 months benefit in PFS. And then you start also to see the benefit in OS. The first trial to show it was Mona Lisa 7, a trial dedicated to young women, so to premenopausal women. And in this case, we added ovarian function suppression. And what you can see here for the overall survival curve, a 30% relative reduction in the risk of death, which is very substantial. And you can see also that the curves start to separate more or less at 2 years. So maybe the CDK4/6 is mostly affecting acquired resistance to endocrine therapy. And very important, look that 60% of these patients had visceral metastasis, and you see an overall survival benefit that you do not see, for example, with chemotherapy. Now we also have survival data from Mona Lisa 3 in postmenopausal women, the same 30% relative risk reduction in the risk of death. So again, very important. We see in this trial in the first line setting and also early relapse and second line setting. In terms of quality of life in the first line setting, most of the trials show no difference in quality of life, with one exception, that's Mona Lisa 7, that has shown an improvement in the quality of life. Why do we see this difference? It's very hard to explain, and it may have to do with methodological issues. But we do see a benefit. But what we can conclude overall is that the use of a CDK4/6 is not negatively impacting quality of life. So do we use a CDK4/6 in first or second line? The majority of the panelists in ABC5 prefers to use it as first line in view of the overall survival benefit. But do we retain that survival benefit in second line? Yes. So this is the summary of the use of CDK4/6 in second line with 6.5 to 7.5 months benefit in PFS, and also some OS benefit. We do not see it statistically significant here in the Paloma 3, probably because this trial was not sufficiently powered to see the OS benefit, unfortunately. But there is a numeric difference in favor of the CDK, but we do see it for the other CDK4/6 inhibitors. For example, for abemaciclib, we see a substantial 9 months benefit in overall survival, reminding you that this disease has a median survival of 3 years, so adding almost another year of survival to these patients. We also see the results for Mona Lisa 3, again, a substantial decrease in mortality of almost 1/3. In terms of quality of life, there is also some heterogeneity, but again, in the second line setting, we see a better or a stronger effect or a positive effect on quality of life with either an improvement or a delayed deterioration, or at the least, we see no major difference between the two arms. So this slide summarizes to you the magnitude of clinical benefit scale for the use of a CDK4/6 in the metastatic setting. In summary, if you use it in first line, the score is more or less 3 because of the no impact in quality of life. If you use it in the second line setting, the score is mostly a 4 because of the positive impact of the quality of life. And if you see, there is one that stands out, which is the one based on Mona Lisa 7, because there is a survival improvement and a quality of life improvement, giving a score of 6, nevertheless, of 5. Nevertheless, we cannot conclude that one CDK4/6 is better than the other. They have never been compared head to head, and we should not waste resources doing that. This is a class effect. So when we decide on first line, do we go for this combination of endocrine plus targeted agents or chemotherapy? We have some trials looking into this comparison. For the moment, it seems that they are at least equivalent in terms of efficacy and compare favorably in terms of safety. But we still have other trials ongoing that may help us with this question. Do we have other options for first-line endocrine-based therapy? So can we use, for example, mTOR inhibitors such as everolimus? We do have a trial called Bolero 4 that looked into the use of everolimus for the first-line setting. Unfortunately, this trial is a non-randomized trial, just one-arm trial. However, I'll call your attention to look at the median PFS, 22 months, which is very similar to what we see in the CDK4/6 trial. So our evidence is lower, but we can still use everolimus in the first line setting if by any chance you do not have an access to CDK4/6. If you do, then CDK4/6 inhibitors should be your first line setting, and we can use everolimus in the second or third line. For the PIK3CA mutated tumors, we have a new treatment option called Alpalicip, and Alpalicip was also studied in first or second line. The majority of patients had not been previously exposed to CDK4/6, and we see a good benefit in terms of PFS, 5.5 months, and a not statistically significant difference in terms of OS. This agent is, however, substantially toxic with a lot of dose adjustments and dose interruptions. So it is probably less efficacious, substantially more toxic than CDK4/6 inhibitors, and therefore it should also be used after a CDK4/6. And I don't have time to go into the details, but we have some data showing that it retains efficacy after a CDK4/6 inhibitor. Finally, In the last San Antonio, we had the presentation of a trial that we were waiting for a long time using an HDAC inhibitor called entinostat. And this drug had given a survival benefit in a previous phase 2 trial. So this is the phase 3, looking into the efficacy of entinostat when added to exemestane. And unfortunately, as you see here, both PFS and OS show no major difference. And so this is a negative phase 3 trial. And for the moment, this drug is not an option for any line of treatment. So summarizing, if we go back to the schema that I showed you in the beginning, for the patients who have a visceral crisis, the indication is chemotherapy. For the patients who we have this low burden, less aggressive biology, we can use endocrine therapy alone, but for the vast majority of patients, our standard is endocrine therapy plus CDK4/6 inhibitors. And this is the new algorithm of ABC5 for the treatment of ER-positive, HER2-negative disease, where you can find all the details of the different options for first, second, and beyond lines of treatment. Thank you very much for your attention, and I invite you all to come to Lisbon this November. I hope that the COVID pandemic would allow us at this time to be again with a face-to-face conference. Thank you.